to NTFLive. Our session today is about how to deal with situations, clinical situations, collegial situations when things go a little bit south. And I know that that's a huge concern of most new graduates that I talk to. So I thoroughly hope that you enjoy the session today. I have a tremendous portfolio of speakers for you today, and I'm going to introduce them one at a time, after which they're going to offer their insights and thoughts from their experiences in crisis and chaos. And then at the end, we will offer you an opportunity to ask any questions, but please do put your questions in the chat as we move along. So I'd like to start with introducing Kirstin Grafstrom. Kirstin was raised in the Shuswap area of BC's interior and began her nursing journey in 2019. After completing her BSN at Thompson Rivers University in 2023, Kirstin joined the Abbotsford Regional Hospital ICU as a new graduate RN in a Med-Surg nursing capacity, with the intent to consolidate her skills in preparation for a career in critical care. In September of 2023, Kirstin was selected to complete the BCIT's Critical Care Nursing Specialty Program, and she completed that with honors in June 2024. Congratulations, Kirstin. Kirstin has now launched a new chapter in her graduate nurse life and looks forward to applying her knowledge as a critical care nurse. Kirstin, welcome. And I'll just get our slides started for you.
No worries. Thank you so much, Judy. Yeah, so my name is Kirstin. Like Judy said, I'm a recent critical care graduate from BCIT. I currently work in Abbotsford Regional Hospital's ICU, and like Judy said, I've been there since graduating nursing school last year. I started in my final preceptorship there after strongly contemplating if I could actually do this. One thing led to another. I accepted and fell in love with ICU nursing, and here I am. Someone once explained new grading in critical care as learning to be learning to be a nurse in general, while having this steep learning curve of learning to be a critical care nurse. And it is daunting, trust me. But it is definitely possible if that's where you want to go. Um, I'd like to make a shout out to my home ICU in Abbotsford. I truly believe that without them, I wouldn't be here today. And thank you to all of them for all the support in my journey so far. When we were planning for this seminar, Judy reached out to me to be kind of like a new grad voice for this seminar. And she asked me to talk to the anxieties and stressors of being a new grad in critical care. And in the beginning, I was like, well, yeah, I have anxieties. Now what? Like, what else do I talk about? And I actually had to sit down with a mentor and like talk about my worries to actually tangibly identify what was making me stressed going into work. And that was a huge part for me, was that, yeah, I felt these anxieties, but I didn't actually know what they were. I didn't know how to address them. So this has kind of been a journey for me as well. The overarching theme in this conversation is, I definitely feel this every morning, was walking into work as a new grad in critical care. You feel like you're walking into the unknown. You feel like you're walking kind of into a void. You feel like you're taking a step of faith every time you walk through those unit doors. Questions of what would I do if blank happens? Will I know? Will I respond appropriately? Will I ask the right people? Will I overreact? These are all big questions that run through my mind daily as I walk into work. A big one that always comes to me in those mornings and throughout the day is, am I overreacting? Am I asking too many questions? Am I making a bigger deal of this than it needs to be? During orientation and mentorship, and even as a student, you're encouraged and it's expected for you to ask many questions. And I always ask so many questions. Love to brainstorm with my orientator or my mentors. But once I was on my own, it felt wrong, almost incompetent of me, doubtful of myself to actually even ask those questions or brainstorm with a colleague, because that patient was now my responsibility. I was able to confide in a colleague a couple weeks after these feelings started, or after I was out of orientation, and they encouraged me that it's okay to ask those questions. It's okay to know what you don't know and ask those questions. That's safe nursing. It took another couple of weeks for me to actually like accept the fact that, yeah, it's okay. I'm not being a bad nurse. I'm not doubtful of myself to ask those questions. I'm trying to be safe. Sometimes you will ask, well, sorry, sometimes I have asked the wrong person. And depending on how they respond, whether intentional or not, has completely affected my confidence as a nurse, my nursing practice, or even sometimes who I am in general. And just like, even if I wanted to do nursing anymore, this didn't last long, but these are strong, strong feelings, and it's never made me feel so incompetent and doubtful of my knowledge and my ability to be a nurse. This has been especially hard when I have that gut feeling, right? I feel everyone's had it, every nurse has had it. You just have a gut feeling that something's not right or something's gonna happen. And you, for me, I've kind of brushed it off in times being, oh, someone with more experience, someone who's smarter than me would have said that or thought of that. But even with my limited nursing experience and very limited critical care experience, I would say about 80% of the time that gut feeling is right or at least partially right, and I should explore it more. So I consciously have to remind myself constantly that even if someone brushes me off, makes it feel like it's no big deal, they've never seen it before, I'm seeing things, whatever it might be, I'm learning to stick to my guns and trust my gut. Sometimes this means I go to a buddy nurse, another buddy nurse. I've gone to PCCs, educators, I've gone to resource nurses, physicians, and often it's either a physician or even a buddy nurse that will listen to my concern, and then they'll actually ask me or encourage me to find more data to see if that is actually what I'm looking for. But I've also learned that when this doesn't go the way I'm thinking it is, or nothing's getting done the way I think it should be done, is I will document everything because I know what I've done. I know that I've done all that I can, and I will document it so that when things happen, hopefully they don't, but sometimes they do, that when things happen, I know I've done my best. That's for me. I know I've done my best and I know I've told everyone that I can. Through all of this, I've definitely felt the need to want to be wanted as a new grad. This has been a significant part of my new grad experience is wanting to contribute to the team. And sometimes when you ask those questions, when you make more work for someone, when you make them come check your patient more, you feel like you're making more work. And as a new grad, I feel that I don't contribute to the team until I can help the team. So doing something for someone else or like anything like that, I don't think that's a quite right indicator for me, especially, or new grads in general, if I'm allowed to generalize, because you just can't. Like, you're so focused on what you're doing, you just can't. But that want to be wanted is such a bad measure on whether or not you can help someone or if you miss something or ask too many questions. I really had to get used to this feeling of not belonging, but then I also had to remember to find my value as a person, not related to my job or my job performance. That was huge. And only then was I able to gain the proper confidence that I could actually make connections at work. I had to find who I was first before I could slowly and surely make those connections as a team at work. So again, thank you for letting me have this opportunity to share my experience.
Well, my goodness, Kirsten. Yes, I agree, Jamie. That was outstanding. And I'm taking you everywhere with me from now on. Because you have epitomized that experience of the newly graduated nurse in such an elegant way. A couple things that really stood out for me before I move on
Of
uh,
course.
was this idea of approaching someone and they tell you to go back and get more data. Well, that's part of that learning, isn't it? Right? So
Oh,
that,
definitely.
right, Kirsten, you come to them and you say, I think I have, and they ask you a few questions and you don't know the answers to them. Okay, that's not a problem. And they say, why don't you go find out and come back to me? Well, the Kirsten has just put that in her little computer. And the next time she goes and reports to someone when something's going wrong, she's already coming with that information. So this is how you learn what information you need. Kirstin. So it's wonderful. And, it just occurred to me that maybe coming to them and saying, I probably need more information for you to make a decision. What information can I get that will help us deal with this situation, so that you don't just think you're coming to them and you should know this. It's like, this is what I know, but probably should get more data. What do you need me to do? So I love that, Kirstin. And I want to reassure you and all the grads here that that feeling of belonging and being able to contribute, so important. But that doesn't come initially. It's really all about you trying to figure yourself out and not looking like you don't know what you're doing. And that takes all of your energy. But after that first stage, in particular, 3 to 4 months, you really do start to be able to lift your gaze and offer rather than needing to receive. So Kirstin, oh, that was just perfect. Thank you so much for that great introduction.
You're so welcome, and thank you for having me.
Oh, what a privilege. I taught Kirstin at True, and of course I taught Cam at the University of Calgary. So this is like homecoming for me. And I'm so proud of you guys and what you're doing. So I just wanted to ensure that people understood where I'm coming from as we start the session. And Kirstin did a wonderful introduction for us. I actually live in Kamloops and would like to acknowledge the lands where I work and live. And as a settler, I'm so incredibly grateful to be able to enjoy this beautiful land, as you can see in this photo. And we certainly encourage you to recognize your lands in the chat if you would like to do that. Again, thank you, Kirstin. I'd like to pull up my notes on Cam. Of course, I knew him a long time ago, but Cam has done a whole lot since I met up with him at the University of Calgary. Cameron Weber is a critical care flight nurse now based in Northern Alberta. With a robust background in nursing and a passion for cardiology, which I totally can relate to, Cameron's journey in healthcare began as a healthcare aide in the operating room and a nursing attendant in the emergency department prior to pursuing his Bachelor of Nursing degree at the University of Calgary. Cam graduated in 2014. Oh my goodness, that was a while ago, Cam. I can't believe how time flies. But since graduation, Cameron has honed his skills in hematology oncology at the Tom Baker Cancer Centre. He spent 3 years on the cardiac surgery unit at the Foothills Medical Centre, and in 2018 ventured into the Canadian Arctic as a critical care flight nurse in Nunavut. Cameron has been honored with the Air Force Association Medal and a Canadian Armed Forces Certificate of Commendation for his outstanding contributions as a civilian during a mass casualty rescue operation. We welcome you, Cam. And just before we get started with your section here, I wanted to actually do a little bit of a poll. So I'm hoping everybody can get on their computers and give us a little bit of a sense as to, who you are, where you're coming from. And we'll just give you a minute or two to do that. Okay, excellent. So we have a lot of nursing educators and new graduates by the look of this. And that's wonderful because it's often the educators, as Jamie is going to attest to, who are working closely in developing the knowledge of the newly graduated nurse. So it looks like we have a student in the audience, but mostly new graduates and nurse educators. So thanks everybody for completing that poll. And Cameron, I'm going to hand it over to you.
Awesome. Thanks, Judy, and welcome everyone. So before we get started, you need to understand that like you, all of us at the panel here, we were once like you in your shoes many moons ago. So let's just have a quick chat and go over some basics that can help you with your transition. So first things first, we're going to go through recognizing clinical decompensation. And I'm just going to focus on shock because it can pertain to several different nursing fields and not just the critical care realm. So shock remains a serious problem associated with high morbidity and mortality. And early treatment is essential, but is hampered by the fact that signs and symptoms of shock appear only after the shock state is well established and the body's compensatory mechanisms have started to fail. So although the cause of shocks are varied, the basic abnormality in all varieties is tissue and cellular dysoxia. So you need to know, is this warm shock or is this cold shock? And so what is warm shock? Well, it's characterized as occurring early and is compensatory in nature with high cardiac output and low peripheral vascular resistance. So we'll see things like fever, shaking or chills, flushed or warm clammy skin, diaphoresis, confusion, disorientation, tachypnea, increased shortness of breath, increased heart rate, increased blood pressure, right? So that's the warm side. So what is cold shock? Well, cold shock is the next phase, and that's where it's late and is uncompensated with decreased cardiac output. And we'll see things like cold, clammy extremities, weak or absent peripheral pulses, severe tachycardia initially, and then eventually that will transition to bradycardia and late shock. And we'll also see what we call MAPS, which is less than 60 millimeters of mercury. And for you new students and grads, when you do a blood pressure, in the brackets is your MAP, okay? So knowing the type of shock also will guide what interventions need to occur. So does the patient need antibiotics or blood products or antihistamines and steroids or inotropic medications or other cardiac medications to help improve cardiac output, okay? But the main thing that I want to stress to you is to have that foundation of know your patient's norms. That is critical. And this is how we gauge what is sick versus not sick. And the best way to do this is to do your own assessments and research. And you need to trust yourself. You have the tools, okay? Just do them, okay? Assess your patients. Do not go off someone else's charting. Be thorough and just be honest, okay? We're there to observe for change, okay? Is there a change, yes or no? Does that change fall within the findings for shock? And is the patient currently receiving treatment for what we've found? Is the problem worsening? Maybe stronger therapy is needed or something different entirely, okay? Then we're going to take those types of findings that we've done, and we need to communicate with the rest of the multidisciplinary team using SBAR. That's the gold standard, okay? Compose your thoughts before you approach them, and we're going to go into more detail about SBAR in a future slide. But we're just going to quickly shift over to assessment. So just remember, the more comfortable with your assessments you get, the faster and more efficient you become. So in 30 seconds of meeting, you can obtain enough information from what you can see, touch, smell, and hear. So when I go in the back of an ambulance to meet the patient first time, I'm doing a quick head-to-toe like an inspection of that patient. Within 30 seconds, I have probably somewhere between 80 and 90% of the information I need. And I haven't pulled out my stethoscope, and this is purely off of observation, okay? So don't discredit assessment, it is key. All right, so tips and tricks for codes. So in AHS, we have what are known as CCMCPs. These are critical care medical control protocols that AHS EMS, including our flight division, are bound by. And it's a little app that you can have on your phone. And these are standing protocols that we are allowed to function within and act as algorithms to follow when responding to a call. And I'm encouraging you all to get in touch with your site resources and find out what kind of algorithms or information they have on the computers or in binders or the things that are going to help you develop as a nurse, okay? Your educators as well will be able to help you with this. They are your resource. Please, please, please reach out to them. They're there to help you, okay? Next, you want to be practicing. So get together with your buddies and go and hang out at a coffee shop or in someone's living room and just do some mock sims. Practice is everything. Us in the air side of life, when we're not busy, we're at the hangar and we're doing mock sims and we're just refining some of our skills because that motor memory is key. And once you get it, then it's very hard to lose or to lose grasp of once you've got it. But yeah, just doing different tasks. That's basically what you want to be doing in those sims. Not always the same role over and over and over again, okay? Practice is everything. And then this is probably the most undervalued piece of advice I can give, but when you're responding to a crisis, you need to breathe, okay? Just stay calm, okay? Compose yourself. If you're in your patient's room, again, rip that call bell out of the wall. Or or press the giant code button on the wall. If that doesn't work, scream down the hallway that you need help, okay? Now, it seems paradoxical, but this is a pro tip. When you're rushing, you're fumbling, and you're not as efficient as you could be. So slow is smooth, and smooth is fast. Okay, so you don't want to, so say you're responding to somebody else's code and you're coming running into the room. Don't fall into the trap of watching for your entertainment, okay? Do a quick inspection of the room, see what people are doing, but also look and see what needs to be done. So find a role you're comfortable with. And just remember, CAB is circulation, airway, breathing. Is somebody up on the chest right now? Is somebody maintaining airway? Has somebody gotten the crash card? Is somebody documenting? Somebody getting meds? You know, these are all thought processes that you should be thinking of. And if all of those patient care side roles are already being utilized, is somebody with the family that might be on scene? Is somebody walking them through what's happening right now, just so that they're aware? Because this is probably their worst nightmare all coming to fruition. And you being there and walking them through what's happening will help them as they kind of deal with that as well. And then the very last point on this slide, after the code, it is imperative that everyone present should participate in a debrief, okay? You need to be talking about what happened. How are people feeling? What went well during the code? What could have gone better? Giving kudos for people's contributions will go far. If anything else, it makes them feel seen and valued and can help build that team dynamic going forward. Debriefs are key, especially in trying to address PTSD and SDSD experiences. So please, please, please reach out and talk amongst yourselves and get the help that you need. And that's going to move us into the next slide, which is acute mental health crisis. So in this profession, you're going to be faced with situations and stress and trauma, and that is going to take its toll. And it's important to be mindful of some early signs of a mental health crisis that we may see when we're at work. This might be with ourselves, it might be with our colleagues. It's not just a provider-patient dynamic, okay? So safety is key when intervening. Make sure you're safe as much as the person can feel safe, okay? Maybe you choose to approach your colleague in the med room where it's more private and offers them the chance to open up. If they do, be sure to listen, to understand, not listen to respond. If you want to help, then they want to feel heard and validated. By the end, you should be encouraging them to do a follow-up with their support networks or the professional resources. And also, you should be familiarizing yourself with the contact information for helplines and crisis teams in your respective areas. And ask yourself, does the situation need a mobile response team or a crisis line? Or are there plenty of other resources available? But knowing which ones is to access is difficult, especially when we don't talk about mental health issues as robustly as we probably could be. So, because you should also be asking, does the situation require going to the hospital? Is this person in danger? Am I in danger? Like, do I need to be mindful of like an escape route things like that. These are all the issues that we need to be asking if we want to intervene in these types of incidences. Okay, so we're going to go into shift handover now. We're going to change gears again. So really quick tip for handing over care, get in the habit of highlighting to the oncoming nurse who you're most worried about and why, and who your most stable is and why. This helps to promote better continuity of care, especially if things change during your shift, okay? Hey, I'm worried about 23A, Mrs. Robinson. Her blood pressures are starting to tank. I think that she's, going into sepsis, okay? You don't have to worry about 28. He's going home in the morning and he's totally independent, okay? That right there, that 30 seconds, like helps them, okay, yep, I know where my focus is, okay? All right. So SBAR, again, we all know what SBAR is. We know it stands for situation, background, assessment, and recommendations. So just my advice when dealing with SBAR is break it down into these 4 segments and stand in front of the mirror and just talk to yourself, okay? And practice your execution for how you want to give this. And you should be, even before you actually do this in real life, you should be going through how you're going to execute this before you start talking to the doc on the phone. So for me, it's like, hey, Dr. Lobe, I'm on scene in High Prairie. I've got a 57-year-old male in septic shock. And then I would go on to B, right? Came in yesterday, he was with pneumonia, and today over the course of the last 12 hours, he's been decompensating. We've just done a blood gas on him. He's currently respiratory acidosis. I think that we're probably going to need to get some broad spectrum antibiotics, and we're going to need to possibly even intubate this guy. My plan is, right? So there's the background, there's the assessment, and then now I'm going into my recommendation. My recommendation is, I think that we should start vancomycin. We need to go ahead and take this person's airway away to safely transport them into the city. My drugs that I want to give are blank, 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 right? Like, you're going through your plan. What do you think? Yeah, sounds good. I would focus on A, B, C, D. Okay, awesome. Thanks. Right? That's how SBAR is meant to work. It paints a picture and it helps everybody kind of understand what's going on and what you're seeing, and helps make sure that we provide the best possible care for those patients. Okay. So those are all kind of low-hanging fruit topics of things that can help you in the immediate phase in your transition. But I'd like to kind of switch gears to something that is a lot harder to do, that I think is going to be allowing you to be the most successful in your lives, not just in your professional career. And that is that we need to grow as individuals, and we need to kind of build ourselves up as we get older. So first things first, there are conversations that are currently taking place within our society, particularly within the realm of developmental psychologists, that point to a disturbing trend of seeing the erosion of the robustness of our social skills within our population. Simply put, these skills are how we interact with the world. And this is a problem because we're social beings. And if these skills are eroding, then our very foundations and tools we have as beings are being affected. And these skills and tools are what we use to navigate the stressors of life, or another word for that is something called resiliency. And this erosion of social skills has direct correlation to a decrease in resiliency, meaning we are more susceptible to greater impacts from things like stress and trauma. And ultimately, it is important that we try and rectify these issues by promoting the development of the individual within the confines of a social structure. We know this to be true because the literature is clear that the best pathway to emotional self-regulation is in service to other people. Inversely, the closer you are to being alone, the more unhappy you will be. So PTSD and SDSD on the front line. This slide is a bit heavy with information, but the takeaway from this is that we have a higher incidence of PTSD and SDSD, also known previously as burnout, in first responders compared to the general population. And so it's important that we understand what we're kind of getting ourselves into within this profession, that you're going to be faced with trauma. And it's important that we know how to navigate that and increase our resiliency. So how do we do that? Well, first things first, again, this is a social answer, right? You need to find your community. That is everything. We are social beings. We do not do well in isolation. So when you go out and engage with your community, make some very good friendships within the organizations or those positive environments that you find yourself in. For me, it was finding my community within a social fraternity like the Freemasons, and I'm able to garner strength from the people that I surround myself with. And I find like-minded individuals that I can try and emulate and learn new things from, right? Like, that's the whole point. And one of the problems that we see is as we become more technological, as we become more digital, we're losing that face-to-face interaction. These social fraternities or organizations or charities, whatever you choose, force you to have more face-to-face interactions. So you need to get out there and you need to find an organization to serve with that you can learn from. So my advice is you need to find the meaning in your life by adopting long-term responsibility. So I'm just going to briefly paraphrase a lecture from Dr. Peterson. So what you want to find is to be found where you least want to find it. This idea is echoed in the prominent stories of dragons and gold. The story of St. George and the dragon is an allegory of facing life's challenges. The dragon represents everything that you're afraid of and is the terrible thing, but it hoards the gold. And so you have to go there in the dragon's lair if you're going to get the gold. And this is a representation of people's paradoxical relationship with reality. It's like you have to go out there and confront it in order to incorporate what it has to offer to you. But the probability that that's going to be intensely dangerous and push you right to the limit, well, first of all, those are actually the same thing. If it didn't push you to the limit, you wouldn't gain anything valuable from it. You don't get one without the other. You don't get the gold without the dragon. So my advice is that you need to get out there and you need to face your dragon and do the things that you haven't been able to do up till now. You know, we know that Gen Z is the first generation that was raised almost entirely by technology and digitized social media. And we've lost that face-to-face interaction. So we need to get back out there and we need to rejoin social organizations. And the ones that have moral structure and values are the ones that I've listed here. And they're the ones that you're going to learn the most values from. And so I think that pretty much sums it up.
Wow, Cam. Wow. I could just keep listening to you for the next couple of hours. That was absolutely outstanding. And it gave us a real snapshot, but you shared those stories and your personal experiences, which made it so real. I certainly relate to the late recognition in my own life of the importance of that social development and that connection with others as being such an integral part of how I developed as a professional. So the fact that these grads and students are hearing this from you now is really helpful. And I will come back to you, Kirstin, to see what your thoughts are on all of that. The challenge of face-to-face is absolutely real for all of us. And I do think that the unpredictability of social relationships are what make you really flexible, as opposed to this very didactic, I'm going to text you or I'm going to email you. I don't see your face. We're not really having an interaction. That doesn't help you when you're dealing with humanity as a nurse. So I so appreciate that, Cam, and we'll probably come back to you with some more questions on your thoughts on that. So I wanted to introduce our final speaker. Jamie Gallagher is a certified healthcare simulation educator and critical care educator and serves as the faculty instructional support lead at Thompson Rivers University here in British Columbia. With a background in education and emergency nursing spanning 17 years, Jamie has held multiple diverse roles in global health nursing, trauma, pediatric emergency, critical care, and simulation facilitation. Jamie teaches for the global network of healthcare simulation debriefing experts at the Debriefing Academy. And we will put that into the chat if anyone is interested in that. And she's currently publishing a paper on emotional debriefing for clinical educators. So welcome, Jamie. It's always been a privilege to work with you. And I'm so glad that you're here today. I'll just
Awesome.
bring your slides up.
Yeah, great. Thank you so much, Judy, for that introduction. And thanks, Cam, for kind of giving a nice interlude to what I'm going to be talking about. So based on the fact that I am a sim educator and have been a clinical educator for years, one thing that I have found relating back to when I was a new grad was clinical event debriefing. And back then I didn't have the language for it and didn't really know what it was. And so my very first experience with what I'm going to be talking about was as a new grad at my very first code. So this goes back to 2007 on cardiac sciences. That seems to be a shared theme with my colleagues here. And we had a lady who went into a hyperkalemic arrest. And during the code and the resuscitation, we were asked to give IV push insulin. Well, this is something that was very unfamiliar to me. I had learned in nursing school about insulin infusions for DKA and, subcutaneous insulin, but I'd never heard of IV push insulin. And I had no idea why the heck we were giving it. It just did not make sense to me. I had not learned about this pathophysiology of intracellular, potassium and insulin. And so we ran this resuscitation in which there was a lot of fumbling for the administration of giving this IV insulin. We didn't have the proper syringes, and even the code nurses didn't really know how to give it. So we ended up debriefing with one of the residents who led the code, and we were able to sit down and ask all these questions as to why we did what we did and what was the goal. And then from that discussion, not only did I learn from it, but we actually made process changes to our crash carts institutionally, and this is at VGH, is that we actually made insulin and hyperkalemia kits at that time because there was such a barrier to the knowledge of how to actually treat this reversible cause of cardiac arrest. And so it was so imperative. And that was my very first exposure to clinical event debriefing. And that was 2007. And I am still equally as passionate about it now in 2024 because I still see the benefits, but I don't feel that it's being talked about enough. So I just really want to give an overview, especially for those educators and new grads, to really understand the impact that it can have and how it's impacted my career so substantially. So yeah, clinical event debriefing is just a really short, facilitated conversation between healthcare professionals, and the research is really profound around this really now that it really can improve team effectiveness by 25%. It improves staff morale, it improves our relationship with each other, it allows for immediate feedback, it promotes self-reflection, and it minimizes frustrations. I use this in my personal life as well. I was just on a kayaking trip with 8 other women over the weekend, and we were doing 3 days out there. And on the second day, I knew that everybody had different agendas for what the next day was. And so we actually, at the end of the second day, I kind of said to my group, I was like, can we just have a debrief about, what we want to do? And we kind of sat back and said, what did we enjoy about the day? What did we maybe not like? And what is everybody's goals for tomorrow? And by doing that, we were really able to determine that within our group of 8 girls, some of who had very strong personalities, that we all had different ideas of what we wanted our final day out on the water to be. And so some people wanted to paddle the whole day. Some people wanted, to tootle around a few of the islands. This is out in the Broken Islands. And then myself and 2 other girls actually wanted to have a bit of a shorter day so we could have a relaxing afternoon. And again, by doing these debriefings, and I use it in my social life, I feel like it really minimizes conflict and minimizes guessing. And so it's a really important tool to kind of have in your toolbox. This slide is important because I just want to make sure that we delineate the difference between critical incident stress management and clinical event debriefing. So when I use the terminology clinical event debriefing, it is really on the ward with your colleagues. It's 5 to 10 minutes. It's a quick chat. Hey guys, what did we do well in that code? What could we improve on? If this exact same thing were to happen tomorrow, how could we do things differently, and highlight any sort of high-level process or system changes? If the event was incredibly traumatic, a pediatric death, or the resuscitation of a colleague, one of our coworkers, or something like that, that you think you are going to have a lot of psychological trauma from, that is critical incident stress management. So that's a different type of debriefing, and that doesn't usually happen right away because the emotions are so intense, and that does need to be a very trained facilitator. So I just want to make sure that we understand that those are 2 different things, and that if you are wanting to have a clinical event debriefing as a new grad, it is not intended that you are there to manage the emotions of your team after a super traumatic event. We can check in and be human with each other, and we have an ethical obligation to really be a companion to our colleagues, but you're not there to emotionally diffuse them after a very traumatic event. That is to be left to the professional. So this slide is just to delineate that the 2 are different, but you can have a critical event debriefing that leads to then a critical incident stress management debriefing days later. So that's what this slide is. And I just wanted to highlight that there are different debriefing frameworks. So depending on where you work and what your comfort level is, you might see these different types of debriefing frameworks, and not one is better than the other. They all kind of highlight the same thing, is that we really want to talk about things that went well, opportunities to improve, points of action. We kind of call this a plus delta. There's pearls, there's gas, so they might be called different things. So for those educators, again, on the call, find something that maybe feels good with you, and there's lots of literature to support whatever tool you really want to use moving forward. This is called the Hot Debriefing Guide. So if anybody is working in BC, I helped develop this with 2 other colleagues a few years ago through the BC Simulation Network and the BC Emergency Medicine Network. So if you're in interior health, you'll probably be used to seeing this. And it is in a couple different health authorities as well. And we just kind of give you a bit of a preamble to kind of set the ground rules that clinical event debriefing within your teams is not there to point fingers or to assess for personal performance. We really want to always make these kind of spaces psychologically safe. And so we're not here, if you do have gross, concerns about somebody's practice, that is a conversation to be had in private. And then sometimes we'll take notes so that we can kind of escalate this to our managers and educators. And then we always kind of use the basic assumption that we believe our team is capable, has done their best, and is seeking to improve. And that's why we're here today. So it's a bit formal. You can use this language or not. Again, it's up to everybody's flavor, but it kind of gives you a bit of a preamble and a structure to use. So this is a tool that you might find throughout the hospitals that you're working at. And then I just wanted to quickly highlight this. Now, Cam spoke to this a little bit regarding PTSD, but I really, in the literature, second victim syndrome is something that really impacts new grads more substantially. And I can really speak to this from experience around, indications of when I've had a patient that had maybe deteriorated, and especially when I was new, I kept thinking it was my fault. There was something I missed. There was something that I did. And I specifically remember working in the CCU, and I flushed this. I had this lady, and she was up and moving around, sitting on the edge of the bed, delightful to talk to. We just had a, lovely morning. I flushed her IV. It had a bit of magnesium in it, and she got all of a sudden a bit flushed. And I was like, oh dear, like that's not, I didn't know. And then I gave her medications. And then as the shift progressed, she started getting worse and worse and worse. And she coded at the end of my shift. And I went home that night, wanting to throw up. I was so distressed and I was so new and I kept blaming myself. What did I do? I must have had a medication error. And so second victim syndrome is exactly that it's an unanticipated adverse event or a medical error that relates to an injury. And the provider is traumatized by that event and that we feel responsible for it. And I almost didn't come back that next day, but I did. And then I found out that she actually ended up coding because she had a pericardial effusion. And that was nothing I did, and I was not responsible for that. But again, we had a bit of a debrief, and I asked for one because I said I just needed to talk this out. And the physician said to me, there is nothing that you could have done that would have changed this outcome. It was only just that it was caught and she was saved. Not by my assessment skills, because I actually had kind of missed a few warning signs, but by the night shift nurse who had some more experience. But again, that just kind of moral distress that I had, it really questioned my ability to stay within this because my anxiety was so high. And so now I have a bit of a term for this, but new grads are very much at risk of second victim syndrome because of that second guessing their skills and knowledge, and because we don't know what we don't know. And so I thought it was related to me flushing her IV that had a little bit of magnesium in it, and it had nothing to do with it. It was very much a physiological deterioration that I couldn't have prevented. So this slide just really speaks to that, and Cam had kind of highlighted it. But again, it just reinforces the importance of debriefing with your team to kind of receive that validation and normalization that as new grads and as newer nurses entering the profession, we take home a lot of things and we have a lot of self-blame, but a lot of times it is a bigger issue, and we need to just kind of talk to our colleagues and hear some validation that we did the right things. There's nothing we could have done that would have changed the outcome, and that can be truly be practice changing and make the difference between people staying in the profession or not. So just how can I use debriefing? So I just normalize it again, get it out there, start using the terminology, start doing some education on it. There is a new article I just sent Judy this morning from Nurse Education Today in 2023 talking about new grad experiences and the importance of it, because the student nurses found relief, confidence, and new ways of thinking through shared understanding. So just really trying to incorporate debriefing into your shifts. So pardon me, debrief with your charge nurse or educator at the end of the day, ask for feedback. What do you think I did well? What do you think I can work on for the next set? Debrief with your team, reflect yourself, maybe journal, something like that, like you can debrief yourself. But a lot of times it helps to do this with others so that you can really have that insight as to what maybe you do need to look up a bit more research and start to improve on, but also really highlight the things that you are doing really well and being really successful with, and things that you really need to leave at the end of the day feeling proud of. And then if you are ever called into a clinical event debriefing, because they are getting more common, thankfully, just really reflect on how even seasoned staff, I've been a nurse for 17 years, there's something I can always learn and do better and get better at, and just see how they all reflect and grow. And that is that growth mindset that we need to have for the entirety of our career. So I just think it's really important that we do attend those and put ourselves in that place to always be wanting to get better and improve. And that is all I have, Judy. Thank you. But yeah, if anybody has any questions, let me know.
Oh, Jamie, that was absolutely fabulous.
No, thanks.
So much about debriefing was not in our wheelhouse when I was in critical care
Mm-hmm. Mm-hmm.
career.
Mm-hmm.
And I suffered from that secondary stress, Cam,
Mm-hmm.
that you introduced and that Jamie talked about for decades.
Mm-hmm. Me too.
I just have to relate one situation. It was fascinating to me because it was a very difficult, it was an 11-year-old boy who had been in a bike accident and had severe brain trauma, and he had obviously increased intracranial pressure, and unfortunately, you know, he had brain matter that we could not contain because of the swelling, and I recall his parents were going to be coming into the room. I was caring for him, and his head was all wrapped up, obviously, but his brain tissue was coming out from the bandages. And I remember, because I didn't want his family to see that, and I remember wiping the tissue from around his face and his eyes and throwing it in the garbage, obviously. And I remember, like, to this day, and I've been in this profession a very long time, to this day, I wondered and wonder what part of him I threw away. And so that absolutely affected me. And one time, like years, if not decades later, we were just all sort of sitting in a very large room with all kinds of allied healthcare professionals and talking about stress experiences that we had had. That came to mind, and when I shared it in front of, had to be like 100 people, I couldn't stop the tears from flowing. And that said to me, that had sat in my psyche all of those years, and it didn't have to. I didn't have a place to put it. And that's, I think, what Jamie and Cam have been talking about for all of you that are new to that kind of trauma, and how do we integrate it, and how do we put it in a place where we can be softer because of it, not set up barriers because of it. So thank you so much for your presentations, and I really appreciated the distinction, Jamie, between the critical event debriefing and the actual more therapist oriented distinction of the help that we need after, and I think we need both. Kate, I'm not sure if we have any questions from the group at this point, but I certainly would encourage everyone to put their questions into the chat or raise your hand. This is very open. This is very informal. Please ask the questions that you have. Until then, Kirstin, I'm wondering if you could give us a few reflections based on what you've heard so far and how that is impacting on you.
Yeah, for sure. I can definitely. So I took a lot of notes. I don't know if anyone was noticing my head down. So one of the ones that, because Jamie talked about it a lot and Cam brought it up first, was the whole debriefing thing. I would say as a new grad, and I'm sure many of you out there can probably relate with this, but sometimes those debriefs don't happen because they did go well. The code went well, the situation went well, which is great, which is awesome. We're happy. But I would say as a new grad, we still need that. Like that would be my call out, is that even if it went well, we caught it in time, we still have those questions of, did we do enough? Did I do enough? I had a lady, was nothing I did. She had been in the ICU for a long time. I was in my Med-Surg capacity. I hadn't gone to school yet. And overnight, she had developed a little bit of a GI bleed. The nurse before me told the PCC. PCC said just to monitor. Anyway, I came in, and so my shift started at 7:15. By 7:45, she was intubated and had already coded once. So that was my team rallying around this patient because they saw it going sideways. And it's not that I didn't, I couldn't keep up. And I remember finding someone I could confide in later and was like, did I do it okay? Like, could I have done better? Like, I just needed that, like Jamie said, validation that A, I didn't cause it, and B, I couldn't have fixed it. Like it was a GI bleed. This patient ended up being in IR for like 6 hours. It was nothing. It was total coincidental. So that was kind of the biggest thing for me, is that even though things go well, and like even me now being less of a new grad, I'm like, yeah, if I had been in that situation with a new grad, I probably wouldn't have thought, oh yeah, they need to talk about it. But definitely feel that we should.
Oh, really appreciate that, Jamie. Sorry, Kirstin. Jamie, go ahead.
Yeah, thanks. I just put in the chat to Catherine, but there is a science and it's in the simulation, but it's the safety science in healthcare has historically focused on reducing primarily, the big bad situations that we debrief and that when things don't go well. But safety too, it's just a terminology, encourages the study of all events, including the routine and mundane, and to really celebrate those successes of the positive ones. And so you're absolutely right, Kirsten. If I could have talked for an hour, this would have come up, but sometimes we just need to like debrief the good ones, because that positive reinforcement of behavior and giving kudos to us as a group for things that did go well is equally as positive as pointing out all the bad. And that's why the literature is actually changing away from the terminology of hot debriefing, because I used to call everything hot debriefing, but hot kind of has this like connotation of like spicy, angry, things went bad. And so we're actually getting away from that of calling it hot debriefing, cold debriefing, and why the literature is actually changing to clinical event debriefing for exactly what you highlighted. So again, you're wise beyond your years, and thank you for bringing that up.
She certainly
Yeah,
is.
of course.
You agree with
Oh,
that.
you guys are too kind.
You know, Kirstin, I was never debriefed, not as a new grad, not as a nurse. It just wasn't part of the nuanced kind of cultural acceptance at the time that I was nursing in direct care. Cam, do you experience debriefing on an ongoing basis in your work?
Absolutely. We do on all of our critical calls. This is the new trend that I think that we've certainly seen since I think 2017. We've really seen a shift. And dispatch knows when it's a bad call. We call them halo events, or high acuity, low opportunity sort of events, that automatically the stress management team or employee resource outreach team will contact you directly at the conclusion of your call. So as soon as on your electronic charting tablet that you've marked that there's a transfer of care, somebody is contacting you to see, how are you? Are you okay? Like, what's going on? Do you want to talk? Like, what went well? What didn't go good? Like, how can we support you? So absolutely, that is happening on the front lines. Is it being utilized effectively? Not yet. There's still that stigma where people are like, yeah, I'm fine, leave me alone. But it is introducing itself out into the realm.
Yeah,
Yeah, I was. Oh,
sorry, go
sorry.
ahead, Kirsten.
No, that's okay. I was actually going to say that, Cam, that I feel like for new grads, I've definitely felt where it's like, yeah, no, I don't want to say anything, but like, would someone talk to me? Right? Like that those debriefs, I think if I dare to pontificate, those debriefs with new grads maybe should be one-on-one, so that we do build this culture of it's okay to talk about it. It's okay to need that validation. Because sometimes we're always like, oh yeah, I could always do this better. Yeah, I knew that I needed to do that better. But sometimes we forget that we can be so negative. We can be so hard on ourselves, especially in critical care. And a lot of nurses are just like, we want to do our best. But it's okay that we want to be comforted too.
Oh, Kirsten, well said. Well said. You know, I did have only once in the many years, 25 years I've been doing research with newly graduated nurses. I have only had one new graduate leave the profession because of an incident. She did come back into the profession about 5 years after this critical incident, but she was working in the emergency department, and she had a 55-year-old man who came in with abdominal pain. And in retrospect, a lot of the senior nurses were like, oh yeah, well, that would be an automatic AAA assessment for me. But for that new graduate, it wasn't, right? Because they didn't have that kind of pattern recognition. And as the patient started to change, they got dusky, their vitals changed, the graduate tried to draw attention to that situation. But the emergency room was so busy that when they'd reach out to someone, that person, in this case, one of the calls that they made out was to a physician going by and said, hey, Jack, can you come and take a look at my patient? And he said, look, I'm just going to put a chest tube in. Do you need me to come right away? And that graduate was like, well, of course I'm not going to tell you to come here instead of going and putting a chest tube in. I don't actually know whether or not this is warranting that kind of attention. And so the grad did try to reach out a couple of times, but everybody was busy. So eventually that patient went to radiology and died on the table from a dissecting aneurysm. That is why that graduate left practice, is they believed it was because of them. No debriefing happened with that graduate. No debriefing happened with me, which is why I sat with that situation impacting my soul all those years. So as a manager, I made sure that I debriefed my staff whenever we had a code, but it still wasn't common practice. So I'm so glad, Cam, to hear that is, I don't know that it's still that way in the hospital though. In Med-Surg, I'd be interested to know from any of the educators on the call here, whether or not that is common practice. I get that it's common practice in flight nursing or even emergency, possibly critical care, but what about Med-Surg? What about, all of the events that go on in hospital care? Is debriefing a part of that picture? Jamie or Cam or Kirstin, are you aware of that?
I'd love to hear if there was anybody else. Obviously, it's happening where I am because we are very passionately trying to roll it out throughout my local site and the local hospital. So it is becoming more commonplace and the literature is really catching up. But again, it is a bit specific to depending on where you are and if you have those early adopters and team champions of it, and also the unit culture and if it's a psychologically safe space, because some wards, some units, some teams really have that and others spaces don't. So I know it's incredibly commonplace in some areas and very routine and very built into the culture of debriefing. And other places it's very not. And it's usually due to the threat to psychological safety, that people don't feel safe discussing team events with each other, which is really unfortunate. But again, those are all opportunities to change and improve. And I think debriefing could really help with that. Mm-hmm.
Absolutely. Thanks so much, Jamie. I really resonated with Kirstin's comment about, new graduates in general, because I absolutely agree that if you're going to debrief with a new graduate, you're probably going to be more effective on a one-to-one because their developmental place is not, you can't expect them to feel comfortable sharing inadequacies or perceived inadequacies in a group. They won't share it, or they'll feel very bad sharing it. So thanks, Kirstin, for that. I did hear in the chat from Fiona Howarth, I'm not sure where you're from, Fiona, but that clinical debriefs are not common in critical care in her health authority, Fraser Health. So yeah, I do think you're right though, Jamie. It's that championing. You've got to have someone who knows how to do it, number one, and number two, believes in it. Pam, you had your hand up, but I didn't give you a chance. Do you want to respond to that?
Oh, I was given a message asking for clarification about a Halo event, but we can.
Okay.
Yeah, so somebody's just wondering, like, what does that mean? So in flight medicine, when we get dispatched on a call, we get tracked as to what kind of diagnoses we're being sent on. And HALO events is an acronym. It stands for high acuity, low occurrence type calls. These are very high stress, very, very acute calls that we do not deal with on a regular basis. So an example might be like DIC. We don't deal with that very often, and this person needs a lot of attention and a lot of hands, and there's a higher instance of something going south on those types of calls, and it's going to put a lot of stress on the staff. And so we know that going into those calls, and so then it's like a positive feedback that we have as these things are getting booked, that while we're being dispatched to go and respond, then other type of resources are being activated as well simultaneously, both to help us after the call, but also activating the types of teams needed when we get there, that kind of stuff. So that's what a Halo event is.
Yeah, thanks very much for that response, Cam. Appreciate that very much. Are there any other questions that the group has for our speakers? I wanted to make sure I share here, and then I will also share in an email to all participants. I'm going to put this in the chat. It is our evaluation form, and you have an opportunity to win a book on professional role transition for the newly graduated nurse. So please do go and complete that survey. We would very much appreciate your feedback on this session, but also on sessions moving forward and what we might be able to do to meet your needs from a synchronous webinar perspective. So I just wanted to thank the speakers. Absolutely outstanding. All I think of is I wish I had this, right, Kirstin, when I was a newly graduated critical care nurse, which I was as well. So I think your experience, Kirstin, is probably going to be a lot better than my experience was, thanks to individuals like Cam and Jamie, who are out there advocating for how to manage and cope with stress, chaos, and crisis as a newly graduated nurse. So I want to thank everyone for participating, and just leaving it once again open to any final questions that anyone might have. And if not, we look forward to seeing you at the next NTFLive session. Thank you, Jamie Gallagher, Cam Weber, and Kirstin Grafstrom for your wonderful presentations to us today.